Hi, doctors. So we'll continue from where we stopped yesterday. So should we start?
Yes, doctor.
So question 1 out of 20. For which one of the following indications is carbamazepine least likely to be useful management option? Least likely. Trigeminal neuralgia, absence seizures, bipolar disorder, temporal lobe epilepsy, focal impaired awareness seizures. So trigeminal neuralgia, carbamazepine is first line, right? Absence seizures is ethosuximide was first line, and second line was sodium valproate. Bipolar disorder, carbamazepine, I don't know, I'm not sure. Temporal lobe epilepsy also, but temporal lobe epilepsy is focal, right? And focal impaired awareness seizures is again focal. For focal is the only indication for carbamazepine, as yeah, that I can remember from yesterday. That to second line.
Yes,
For
yeah,
focal,
absence
first
is
is
second.
lamivudine and levetiracetam,
Absence is
and second one is second line is carbamazepine, oxcarbamazepine, and one more drug. So these were second line for focal impaired seizures. We said it's most unuseful in epilepsy management. So I think maybe absence seizures because I haven't seen carbamazepine anywhere in any other type of seizure disorder. Let's see. Yeah, absence seizures. Correct answer is absence seizures. Carbamazepine, a sodium channel blocker, is not typically used in the management of absence seizures. This is type of seizure primarily seen in children, characterized by brief loss of consciousness or awareness without any of the other notable symptoms. Medications such as doctor, I will mute you for some time. Yeah, thank you. So medications such as ethosuximide and valproic acid are more commonly used to manage absence seizures due to their ability to inhibit type T-type calcium channels, which are thought to be involved in the pathogenesis of this condition. Okay, so trigeminal neuralgia, we will see. They are saying why this is correct, why this is right. We'll see carbamazepine uses here. Carbamazepine is chemically similar to tricyclic antidepressant drugs. Okay, it is because of sodium channel some problem, no? Sorry, sodium channel. What is the mechanism of action here? It was given. Mm,
sodium channel blocker.
yeah, yeah, here only. Sodium channel blocker it is. So it is similar to the tricyclic antidepressants, and it is most commonly used in the treatment of epilepsy, particularly partial seizures, where carbamazepine remains first line medication. Other uses include, they are saying first line, but then it was given yesterday that it is second line. And other than that, other uses are trigeminal neuralgia and bipolar disorder. Mechanism of action binds to sodium channels, increases the refractory period. Adverse effects, it's a P450 enzyme inducer, dizziness, ataxia, drowsiness, headache, visual disturbances, especially diplopia. Diplopia from carbamazepine, Steven-Johnson syndrome, leukopenia and agranulocytosis. So see, there was some of the C drugs which were causing agranulocytosis. One is carbamazepine. Another one, others, three C drugs. I will tell you which one they are later. And Steven Johnson syndrome also, hyponatremia secondary to CRD. Carbamazepine is known to exhibit autoinduction. Hence, when patients start carbamazepine, they may see a return of seizures after 3 to 4 weeks of treatment. Okay, carbamazepine will induce enzymes which are needed for the metabolism of carbamazepine itself. So, there will be some tolerance after some time, return of seizures after 3 to 4 weeks of treatment. You see a 35-year-old male patient with right side facial paralysis started about 3 days ago and has slowly become worse. He's unable to raise his forehead, close his right eye. Also notice that his taste has been altered on the right side. He is not particularly worried because it happens 12 months ago. We have seen this question. So regarding Bell's palsy, they ask him what is the correct statement. First line treatment is prednisolone and antiviral treatment for 10 days. First line treatment is with antiviral therapy for 10 days. So antiviral therapy, both are wrong because antiviral is not indicated nowadays by NICE. So both these options are wrong. Loss of taste and two-thirds of the tongue is in a patient with Bell's palsy. Is a red flag sign. No, it is normal in Bell's palsy. A patient with recurrent Bell's palsy needs urgent referral to ENT. Yes, this was the answer. Occasionally,
This
Bell's
is
palsy is bilateral. No, that is also wrong. Yes, doctor?
I said the fourth one is
Yeah,
right.
yeah, the fourth one is right. So we read about this. Maybe it's a repeat question from yesterday. A 34-year-old financial gains representative present to the routine surgery with a 2 week history of droopy left eyelid and forehead weakness. This is confirmed by examination and there are no other ocular or ear findings. And this is a 2 week history. Huh? What is important part of treatment? Antiviral treatment, antibiotic, immediate ENT referral, nighttime eyelid coverings, topical steroids. So at this point
So
of
it's
time,
night time.
yeah, after 2 weeks of presentation, what you will give them? Only nighttime eyelid
Nighttime
coverings.
eyelid coverage.
No need topical steroids also. Oral steroids they
No.
have not even given. Eye care is important in Bell's palsy. Drops, lubricants, and nighttime taping should be considered. 40-year-old man presents with an excruciating right-sided headache for the last 1 hour. His eye has been watering excessively and he also has a blocked nose. So a headache, watery eye and blocked nose looks like cluster headache. He had 5 similar episodes in past 2 weeks, each lasting approximately 2 hours. He has felt well in between each episode. He smokes 20 cigarettes a day. On examination, is extremely restless and is pacing around the room. He is apyrexial, blood pressure is 145 by 90. It is difficult to perform neurological examination as his distress when you notice that his right pupil is more constricted than the left. Let's go back again. Right-sided headache, 1 hour, right eye pain. Eye has been watering excessively and also has a blocked nose. But there's a blocked nose also, right?
It's a cluster.
Cluster
Cluster
only, no,
headache.
not glaucoma. I just went back to see whether it was glaucoma or something. It is difficult to perform neurological examination as he's distressed, but you notice his right pupil is more constricted than left. Besides referring to neurologist to confirm the diagnosis, what acute treatment can be offered to relieve his symptoms? So cluster headache, subcutaneous sumatriptan, oral sumatriptan, high flow oxygen at home,
High
oral
flow
morphine,
oxygen.
verapamil.
Yes, giving high flow oxygen. High flow oxygen we usually give in the cluster headache.
Okay. Subcutaneous sumatriptan is the answer. Cluster headache, acute treatment, subcutaneous sumatriptan plus 100% oxygen. Okay. So they said high flow oxygen but not 100% oxygen.
Exactly.
Okay.
100% oxygen.
Yeah. So this man has classic symptoms of cluster headache with bouts of severe unilateral headache lasting 15 to 180 minutes associated with ipsilateral lacrimation, nasal congestion and meiosis. Meiosis also is a characteristic feature of cluster headache. Cutaneous triptans are effective in managing the acute bouts of cluster headache. Intranasal triptans can provide rapid relief, although subcutaneous have been shown to be more effective. There is no evidence to support opioids, NSAIDs, or paracetamol oral triptans as they should not be used in this situation. Short burst oxygen therapy can also be offered for rapid relief, but his current smoking status would render the use of home oxygen unsafe. Okay, that is the reason why not home oxygen. Verapamil is used as a preventive treatment for cluster headache rather than acute symptomatic relief. Cluster headache. Cluster headache is also known to be one of the most painful conditions that patients can have a misfortune to suffer. The name relates to the pattern of headaches that typically occur in clusters lasting several weeks, with clusters themselves becoming typically once a year. The cluster headaches are more common in men, 3:1, and smokers. Alcohol may trigger an attack, and there also appears to be relation to nocturnal sleep. Features: intense sharp stabbing pain around one eye. Pain typically occurs once or twice a day, each episode lasting 15 to 2 minutes to 2 hours. The patient is restless and agitated during an attack due to severity. Cluster typically lasts 4 to 12 weeks. accompanied by redness, lacrimation, lid swelling, nasal stuffiness, miosis, ptosis in a minority. Most patients will have neuroimaging. Underlying brain lesions are sometimes found if clinical symptoms are typical for, even if clinical features are typical for cluster. MRI with gadolinium contrast is the investigation of choice. Management. NICE recommends seeking specialist advice from neurologists if a patient develops cluster headaches. Acute condition. 100% oxygen, 80% response rate within 15 minutes. Subcutaneous triptan, 75% response rate within 15 minutes. Here, why we did not give him oxygen or home oxygen is because he is smoking a lot. Prophylaxis. Verapamil is the drug of choice. There is also some evidence to support a tapering dose of prednisolone. Some neurologists use the term trigeminal autonomic cephalalgia to group a number of conditions including cluster headache, paroxysmal hemicrania, short-lived unilateral neurologiform headache with conjunctival injection and tearing is CUNT. It is recommended that such patients are referred to specialist assessment for specific treatment may be required. For example, it is known that paroxysmal hemicrania responsible to indomethacin. So you see a 49-year man who has seen a hematologist who has prescribed him apixaban following his pulmonary embolism. He's on other medications for his comorbidities. Which medication could interact with apixaban? This we have done yesterday. Allopurinol, carbamazepine, losartan, metformin, simvastatin. Quick answer, doctor. Yesterday's question.
You made for
What? Apixaban, the drug in this, the one which react should not be co-prescribed with apixaban is
carbamazepine.
carbamazepine because it's an enzyme inducer, and apixaban is not like any multivitamin that whether little dose decrease or increase is fine because it is required for a particular reason that there should be anticoagulation. So it's important that its dosage should be as required. So carbamazepine should not be given along with apixaban. A 23-year-old man presents to his GP. He describes episodes of leg weakness following bouts of laughing while out with his friends. The following weekend, his friends describe brief collapse following a similar episode. What is the most likely diagnosis? Stroke Adams syndrome attack, cataplexy, hypokalemic periodic paralysis, absence seizures, myasthenia gravis.
Second option, doctor.
Cataplexy?
Yes.
Yes. Laughter leading to fall or collapse is cataplexy. Correct answer in this case is cataplexy is a sudden and transient episode of muscle weakness typically triggered by strong emotions like laughter, anger or surprise. It is often associated with narcolepsy, a sleep disorder that causes excessive daytime sleepiness and fragmented nighttime sleep. The patient symptoms of leg weakness following bouts of laughter and brief collapse are characteristic of cataplexy. Stroke attacks are transient loss of consciousness due to decreased blood flow to the brain caused by heart block. Stroke attacks are usually accompanied by symptoms such as dizziness, palpitation, or chest pain. In this case, the patient's symptoms are not suggestive of cardiac origin. So, if there is stroke attack, you are supposed to expect dizziness, palpitation, or chest pain, which is not the case here. Hypokalemic periodic paralysis is another incorrect option. This condition characterized by episodes of muscle weakness or paralysis associated with low potassium levels in the blood. These episodes can last hours to days and can be triggered by factors such as stress, cold, temperatures, carbohydrate-rich meals like biryani. However, the patient's symptoms can be triggered specifically by laughter, makes hypokalemic periodic paralysis less likely. So absence seizures, brief episodes of impaired consciousness without any accompanying motor symptoms. So blank or staring appearance. Myasthenia gravis is autoimmune disorder that causes muscle weakness due to impaired transmission at the neuromuscular junction. Symptoms of myasthenia gravis tend to worsen after repeated use of affected muscles and improve with rest. While the patient's symptoms could suggest muscle weakness, the specific trigger of laughter and transient nature makes myasthenia less likely. Okay. So most likely diagnosis here is cataplexy, sudden transient loss of muscle tone caused by strong emotion. Around two-thirds of the patients with narcolepsy have cataplexy. Buckling knees to collapse. What was that? Features range from buckling knees to collapse. Okay. Each one of the following drugs are known to induce cytochrome P450 enzyme except inducers except phenobarbital does induce, brezorfalvin only antifungal that induces, rifampin only antibiotic that induces, carbamazepine is an inducer. Isolated as it is not an inducer inhibitor. Okay. So, a 28-year man presents with severe intermittent piercing left-sided frontotemporal headache over the past few days. It seems to occur early in the morning and around the same time each day, lasts 15 minutes to 2 hours. Again, 15 minutes to 2 hours. 2 hours is the limit for cluster. He feels sick at the time and is unable to lie still. Similar episode last year. Okay. Full neurological examination where headache is free is entirely normal. What is most likely underlying diagnosis? So, carotid artery dissection, cluster headache, migraine, trigeminal neuralgia, venous sinus thrombosis. Sinus, this is cluster headache, definitely. Migraine will not be like one episode last year and one episode will be here or similar episodes. Photophobia and phonophobia are specific for migraine. That is not mentioned anywhere here. One of the diagnostic criteria for migraine headache. Carotid artery dissection will be not recurrent. Trigeminal neuralgia will have sharp, what do you say, electric shock like pain
Pain in
with
also.
specific trigger areas, right?
And what about the venous sinus thrombosis?
Venous thrombosis will not be recurrent. So these are recurrent attacks, and in between the attacks, they are completely normal, right?
Mhm.
So sinus thrombosis, once it is there, it is there. So it will be a continuous headache. A cluster headache is most likely due to the patient demographics, quality of pain described, intermittent nature, relatively short duration. The other pointers to this diagnosis is similar headache occurring in the previous year. So carotid artery dissection often occurring, including neck pain, neurological symptoms would not account for the same symptoms per 1 year previously. Okay, same thing. Venous sinus thrombosis will present with gradually worsening headache and often a neurological deficit. Trigeminal, I told you already, while brushing the teeth or affect more the women, people over 50 years. Distribution of pain tends to be more facial rather than frontotemporal in trigeminal neuralgia. Migraine, alongside it will be unusual for migraines to occur around the same time in each day and clusters day to day, and they would tend to last longer than 15 minutes to 2 hours. So cluster, we have read about the cluster. Even a reducing dose of prednisolone is good for treatment of cluster headaches. So during your weekly ward round, a local neurological rehabilitation care center, you see a 36-year-old man who has a background of depression, asthma, and traumatic spinal cord injury. The nurses report him being more distressed and agitated over the last 2 days only. On examination, he is profusely sweating in the upper body and face, and his blood pressure is 180 by 110. Heart rate is 60, oxygen saturation is 99, chest is clear to auscultation, Glasgow Coma scale is 15, calves are soft and non-tender, pupils are equal and reactive. He admits to drinking 15 units per week and smoking 10 cigarettes per day. Regular medications include salbutamol, oxycodone, cocodamol, as and required, and prophylactic low molecular weight heparin. What is the most likely underlying cause of the patient's symptoms? So he's only sweating in the upper body and face, and his blood pressure is high. Looks like autonomic symptoms, right? Heart rate is low, BP is high. Uh, so is it alcohol withdrawal? No, he's continuing. No, he's drinking alcohol already. Autonomic.
Yeah, and all is 15 units per week. That is okay. Not much.
Yeah. So, sorry, autonomic dysreflexia could be the cause because these are all autonomic symptoms, right? Pulmonary embolism, his oxygen sat is 99% and chest is clear to auscultation, right? Oxygen sat is fine. And in most important thing is tachycardia and tachypnea are important. Tachycardia is more important in pulmonary embolism,
Pulmonary embolism.
whereas here he is having bradycardia. Pulmonary
Is
embolism,
he having depression?
he is having
Is he taking
bradycardia.
anything? No, is he having depression? Is he taking anything? Serotonin or something?
No, no, his medication is only salbutamol, oxycodone, cocodamol,
Okay.
and heparin. He is, yeah, depression, distressed, and agitated.
Background
Only
of
2 days.
depression, but he is not taking anything for that.
No, he's
So we
distressed.
should rule out serotonin
Yeah,
syndrome.
serotonin syndrome is ruled out because there is no two medications, salbutamol, oxycodone, cocodamol, and low dose heparin. So these will not react. These do not.
So second option.
Yeah, thyrotoxicosis. Why only upper part of the body and face will be affected,
Hmm.
right? Autonomic dysreflexia. Fecal impaction or urinary retention are most common triggers of autonomic dysreflexia. Reflexia. Okay. Fecal impaction and urinary retention most common triggers of autonomic dysreflexia. Autonomic dysreflexia is the correct answer. The treatment of autonomic dysreflexia involves removing the underlying cause. In this case, most likely fecal impaction. Risk factors for impaction include immobility or bed-bound status, medications that cause hypomotility like cocodamol in this case, anatomic conditions such as anal fissure, past anal surgery, Hirschsprung disease, neuropsychiatric conditions such as dementia, or previous traumatic spinal cord injury. So already was having traumatic spinal cord injury also, right? And he's on cocodamol also, and he's not taking any laxative. Fecal impaction may have been caused by use of oxycodone, PRN, cocodamol use without any accompanying laxatives. This is the only answer that would cause localized flushing above the level of the cord lesion. Okay. Alcohol withdrawal is incorrect. Physical symptoms of alcohol withdrawal would not be expected if the patient was drinking 25 units per week. Pulmonary embolism is incorrect. You would expect tachycardia, possibly low blood pressure or signs of a DVT, right? We were thinking. Serotonin syndrome is incorrect. It could produce similar clinical picture but would not cause localized sweating as with autonomic dysreflexia. You will also expect tachycardia and dilated pupils in serotonin syndrome. Thyrotoxicosis, it will not produce localized sweating. There may also be other signs of thyrotoxicosis like tachycardia, palpitations, and tremor. Okay, this is the same thing. So yeah, there is some explanation. This clinical syndrome occurs in patients who have had a spinal cord injury at or above the T6 spinal level. T6 spinal level. Briefly, efferent signals may commonly be triggered by fecal impaction or urinary retention, but many other triggers have been reported. Cause a sympathetic spinal reflex via the thoracolumbar outflow. The usual centrally mediated parasympathetic response, however, is prevented by the cord lesion. So above the T6 spinal level lesion, if it is there, then it will cause autonomic dysreflexia. This results in unbalanced physiological response characterized by extreme hypertension, flushing, sweating above the level of the cord, agitation, and untreated cases, severe consequences of extreme hypertension have been reported. Example, hemorrhagic stroke. Management of autonomic dysreflexia involves removal of control of the stimulus and treatment of any life-threatening hypertension or bradycardia. So the stimulus has to be removed. So fecal impaction or urinary retention should be taken care of. So a 54-year-old man presents with a 2-day history of left-sided facial droop. He is otherwise well with no associated facial pain, eye symptoms or neurological symptoms. So only 2 days history, left-sided facial droop. There's no history of trauma. On examination, unilateral facial weakness involving the whole of his left face. He was unable to close his left eye. The rest of the neurological examination is normal. There's no rash in his ears, face or mouth, and his neck is soft with no palpable swellings or lymphadenopathy. So everything else is ruled out. What is the most appropriate management for this patient? So it's a Bell's palsy. What will be the management? Comments on course of prednisolone. He has come within 2 days. Yes, this could be right. Comments on course of prednisolone and acyclovir. Acyclovir, wherever it is there, it is wrong. Comments on course of prednisolone and give eye care advice. Yes, this is more better. Refer to ophthalmology, not required urgently. Urgent referral to secondary care is also not required. So I think third is the answer. Right? Okay. So 11, a patient is given ondansetron for chemotherapy-related nausea. What is the most likely side effect of ondansetron? Constipation, dry mouth, insomnia, visual disturbance, pruritus. I have no idea.
I think insomnia, I will guess.
Ondansetron is a serotonin 5-HT3 receptor antagonist.
5-HT inhibitors.
Yeah, what will it cause? Something related to serotonin. Constipation, dry mouth, insomnia,
I
visual
think
disturbance.
insomnia.
Yeah, I will also guess
Hmm.
insomnia. No, it's constipation. While all the above may cause constipation,
Constipation.
whilst all the above may occur, constipation is more common. Okay, all of these are side effects of ondansetron, but constipation is more common, it seems. So 5-HT3 antagonists are antiemetics used mainly in the management of chemotherapy-related nausea. This may act in the chemoreceptor trigger zone area in the medulla oblongata. Examples: ondansetron, palnosetron, second generation 5-HT3 antagonist. Main advantage is reduced effect on the QT interval. Palnosetron, Adverse effects, prolonged QT interval and constipation is common. Okay, like codeine, ondansetron also causes constipation. A 40-year-old woman presents as she has noticed a droop in her right side of her face since she woke up. Again, it's a Bell's palsy thing. There is no associated limb weakness, dysphagia, visual disturbance. You on examination, you notice that right sided upper and lower facial paralysis. Which one of the following features would be more consistent with diagnosis of Bell's palsy? Okay, they have not diagnosed Bell's palsy. They're saying there's upper and lower face weakness on one side. Vesicular rash around the ear? No, that will be Ramsay Hunt syndrome. Hyperacusis? Yes. Sensory loss over the distribution of the facial nerve? No. No sensory. Facial is completely okay. Facial is completely motor nerve, right? No sensory loss in that case. Pins and needles in the right arm? Why? Rhinorrhea? No. So, which of the following features will be more consistent? Means hyperacusis. So the
Hyperacusis.
yeah,
Yes.
there were four of them. One was hyperacusis, one was pain, yeah, post-auricular pain preceding paralysis, altered taste, dry eyes, and hyperacusis. Vesicular rash around the ear would suggest a diagnosis of Ramsay-Hunter syndrome. Hyperacusis seen in around third of the patients with Bell's palsy. A 9-year boy is brought to the surgery with recurrent headaches. What is the most common cause of headaches in children? Migraine, depression, refractive errors, tension headache, and cluster headache. I think refractive errors. 9-year-old. What do you say, doctors? Migraine? No, not depression in children. Tension headache would be more common also. But why?
In kids, there is refractive error is most
I
common. Migraine is common. Migraine in the kids. Migraine, we will go with migraine. In the kids, it's bilateral
yeah,
and also they have
but
GIT
I
symptoms.
think more common is refractive errors. Oh, migraine is
Migraine.
correct, right? Migraine is the most common cause of primary headache in children. Oh, I did not know that.
Yes, and they will present with GI symptoms more.
Yeah. So some of the
Yeah. And
following,
it is, I think, bilateral in children,
yeah,
migraine.
bilateral is more common in children. Yes. Some of the following is based on excellent review article of Great Ormond Street Hospital website. Epidemiology, up to 50% of 7-year-olds and up to 80% of 15 years old have experienced at least one headache, equally as common in boys and girls until puberty, and then strong female preponderance is seen in for headache. So till puberty, both male and female kids will get headaches, but after puberty, females get more headache. Yeah, migraine. Migraine is not always the most common cause of primary headache in children. The International Society, Headache Society, have produced criteria for pediatric migraine without aura. More than 5 attacks fulfilling B to D. Headache lasting 4 to 72 hours. Headache has at least two of the following features: bilateral, unilateral, frontal, temporal location, pulsating quality, moderate to severe intensity, aggravated by routine physical activity. At least one of the following accompanies the headache, like nausea or vomiting, or photophobia and phonophobia, may be inferred from the behavior of the kid. Acute management, ibuprofen is thought to be more effective than paracetamol in pediatric migraine. This is also one thing that is important. NICE recommends that triptans may be used in children more than 12 years, but is often follow-up is required. Sumatriptan nasal spray again. Here in kids is nasal spray. In adults, it's subcutaneous triptan. Is the only triptan that has proven efficiency but is poorly tolerated by young people who do not like the taste in the back of the throat. It should be noted that oral triptans are not currently licensed for people under 18. Side effects of triptans include tingling, heat, heaviness, or pressure sensations. Prophylaxis. The evidence base is limited and no clear consistent guidelines occur. The GOSH website states, in practice, pizotifen, propranolol should be used as first-line prevention in children. So this is another thing. Pizotifen was not recommended in adults, but in kids it is recommended, and propranolol. Second-line preventives are valproate, topiramate, and amitriptyline. Again here, sodium valproate is also listed as second-line preventive for migraines. Topiramate and amitriptyline we know already as for adults. So TTH, tension headache, at least 10 previous episodes fulfilling criteria B to D. Head, anything else is here? Second most common type of headache in children. Diagnostic criteria for TTH is 10 previous headaches fulfilling B to D. Headache lasting 30 minutes to 7 days. This is long lasting headache. At least two of the following pain characteristics. Pressing or tightening, non-pulsating quality, mild moderate intensity may inhibit but does not prohibit activity. Bilateral location, no aggravation by routine physical activity. Both of the following: no nausea, no vomiting. Photophobia or phonophobia, or one but not the other is present. So any one of photo or phonophobia will be present. So this is for tension headache. Is the second most common. A 25-year-old man presents for review for the past year. He has been experiencing headaches. He's only 25. Now occurring around 5 to 6 times per month, typically lasting all day. They are not associated with any form of aura. Typical headache is described as severe throbbing pain in both sides of the head, associated with nausea and lethargy. When he gets such headache, he typically goes back to bed, so he sleep on it. Sleep it off as an activity such as waking or climbing the stairs make it worse. Before going to bed, he typically takes one of his father's diclofenac tablet, which seems to help. Neurological examinations are remarkable. What is the most likely diagnosis? So here it is bilateral, but all other features are associated with migraine, right? So migraine, cluster headache, medication overuse headache, tension headache, raised intracranial pressure. What about medication overuse headache?
Maybe he's taking father's medication.
No, there is a typical symptoms. See, nausea is there. He has to sleep. It is affecting his
The
work.
migraine?
It's migraine, even though it is this.
Yeah.
So, and he's only taking one of diclofenac tablets when he's having bed. It is before going to bed. Okay. So every day before going to bed, he takes one of his father's tablets. Last all day when it occurs. So could be medication overuse headache.
Yeah.
That's what they are asking, or migraine. Migraine. Headache is very likely to represent a migraine. Much of the history is very typical, except that majority of patients usually have unilateral symptoms. There's evidence of no evidence of the kind of medication overuse that can result in regular headaches. Okay, diclofenac is not the kind of medication that will lead to medication overuse headache. I think opioid is one of them, but the other one I don't remember which one. Mm. So this one is for adult migraine diagnostic criteria. 5 attacks fulfilling BND, headaches lasting 4 to 72 hours, untreated and unsuccessfully treated. Unsuccessfully treated. Headache has at least two of the following characteristics: unilateral location, pulsating quality, varying with heartbeat, moderate or severe pain intensity, or aggravation or causing avoidance of routine physical activity like walking or climbing the stairs. During the headache, at least one: nausea, vomiting, photophobia, and phonophobia. Not attributed to any other disorder. History and examination do not suggest secondary headache disorder or is ruled out by appropriate investigation, so headache attacks do not occur for the first time in close temporal relation to the other. Okay. So in children, the attacks may be shorter lasting, headache is more commonly bilateral, and gastrointestinal disturbance is more prominent. Migraine with aura, around 25% of migraine patients have migraine with aura, tends to be easier to diagnose. A typical aura being progressive in nature may occur in hours prior to the headache. Typical aura includes transient hemianopic disturbance or spreading scintillating scotoma, jagged crescent. Sensory symptoms may also occur. So this was also asked in two questions. If we compare these guidelines, NICE criteria, the points are noted. NICE suggests migraines can be unilateral, bilateral. NICE also gives more detail about typical auras. Auras may occur without headache, with or without headache, are fully reversible, develop at least over 5 minutes, and last 5 to 60 minutes. Following aura symptoms are atypical and may prompt further investigation like motor weakness, double vision, visual symptoms affecting only one eye, poor balance, decreased level of consciousness. So here why it is not medication overuse headache is because that the kind of medication that he's overusing is not the one that is implicated in medication overuse headache. And what are the medications we will see again when we come to that topic. 58-year-old woman with multiple sclerosis, intractable spasticity has failed to respond to conventional treatments. I think we read about this. She sees her GP because she would like a prescription of medical cannabis as she has read several success stories on the internet. This topic we have read. What is the most appropriate action for a GP to take? She came to the GP for a prescription for cannabis-based product. Cannabis-based product can only be prescribed by a doctor on a GMC medical register, specialist register, right? Ask the patient consultant to consider initiating medical cannabis. Decline explaining there is no evidence for this treatment. Decline explaining this treatment is not available on NHS and can be purchased online. Refer to a local GP with specialist interest in neurology. Start THC CBD spray.
First one.
Yeah, I did first one.
Uh,
Okay. Yeah, current guidelines says unlicensed cannabis products can only be prescribed by doctors on GMC register, and that specialist register, and that doctors should prescribe products for only disorders within their specialty when there is clear evidence for published guidelines. So only the neurologist can prescribe THC CBD spray for spasticity. Likewise, only an oncologist can prescribe the cannabis-based medicine for what is that? Intractable vomiting. It's like that. So only that particular specialist can initiate the treatment, like nabilone can be initiated by chemotherapy means oncologist only. So one thing we did not read yesterday, common side effects that have been associated with cannabis-based medicines in order of frequency. Same like cannabis, the effects of cannabis or side effects of cannabis-based treatment include disorientation, dizziness, euphoria, confusion, dry mouth, nausea, somnolence, fatigue, vomiting, drowsiness, loss of balance, and hallucinations. Rare adverse effects include psychosis and seizures. A 44-year-old woman presents to us with a 60-hour history of left-sided facial muscle weakness. Already 60 hours means 5 days, huh? No, 12, 12, no. 60 hours means less than 2.5 days.
it is,
2.5 days,
yes.
right? Last time also I got confused with this. Left-sided facial muscle weakness. She has no pre-existing medical conditions and does not take any regular medication. First noted the symptoms while on camping holiday, attributes this to a delay in seeking medication. On examination, she has left-sided facial nerve palsy with no sparing of the forehead movement. Remainder of the cranial nerves are normal and there's no neurological deficit in the upper or lower limbs. What is the most appropriate management? So she has come within 3 days. So Cummins oral prednisolone. Cummins oral acyclovir is not the guideline. Cummins prednisolone can be there. Cummins prednisolone oral acyclovir is not the guideline. Urgently refer to ANT not required. Self-care measures only as she is outside the drug treatment window. No. So oral prednisolone. Okay, doctors, we'll go to the next question. 56-year-old woman comes for a review around 4 weeks and she had blistering rash under her right breast which extended around the back and diagnosis of shingles was made. Unfortunately, at that time she has been experiencing severe shooting pains. The skin was also very tender to touch. Neither paracetamol nor ibuprofen has helped her symptoms. What is the most appropriate next line treatment for herpetic neuralgia?
Acceptable.
4 weeks ago, right? She had a rash. So this is post-herpetic neuralgia. Lignocaine patch,
Amitriptyline.
yes. Tramadol, amitriptyline, carbimazole, diclofenac. I think amitriptyline,
Amitriptyline would give neurological pain.
neurological pain first, and first line is amitriptyline and other drugs. After that, lidocaine patch also diclofenac. No, lidocaine patch can be given. This lady has developed post-herpetic neuralgia. Nice recommend using amitriptyline, duloxetine, gabapentin, and pregabalin first line. Neuropathic pain include uh, pain which arises from damage or disruption of nervous system, often used difficult to treat and responds poorly to standard analgesia, post-diabetic neuropathy, post-herpetic neuralgia, trigeminal neuralgia, prolapsed intervertebral disc. These are the four diseases that will cause neurologic pain. First line treatment, amitriptyline, duloxetine, gabapentin or pregabalin. First line drug treatment does not work. Try other of the three drugs. Contrast to standard analgesics, drugs for neuropathic pain are typically used as monotherapy. If not working, the drug should be switched, not added. Tramadol may be used for rescue therapy. Capsaicin, topical capsaicin may be used for localized neuropathic pain post-herpetic neuralgia. So topical capsaicin can also be used. Pain management clinics may be useful in patients with resistant problems. Please note that for some specific conditions, the guidance may vary. For example, carbamazepine is used first line in trigeminal neuralgia. Okay. 34-year-old man presents with episodes of severe pain around his right eye. Occur once or twice a day and typically last 30 minutes. Episode started around 1 week ago while severe have not been getting worse. During an attack, his girlfriend reports his eyes go red and starts to water. Examination of his eye now include in visual activity is normal. His last episode was around 3 hours ago. He is now pain free. What is the most appropriate next step? Right now he is pain free. Wherein same day ophthalmology review, discuss with neurologist and need for neuroimaging, start carbamazepine, start propranolol, advise him to take paracetamol and ibuprofen if he has further attacks. This looks like a
Cluster?
cluster headache, right? 30 minutes.
Yes, cluster headache. I think last option.
Paracetamol and ibuprofen will not help with cluster headaches, no dear.
So, like migraine.
Maybe discuss with a neurologist, right? Because every cluster headache case should be referred to a neurologist to rule out anything
Must
else.
be.
I am thinking that.
I should not start prophylaxis.
What will you give
Prophylaxis
prophylaxis for
is the verapamil for
verapamil? No, it's not there in the
cluster.
OC. And pain is
Okay, we
around
will
the
go.
right eye, not in the right eye. So it's not a ophthalmic problem. Discuss with neurologist
Mm.
need for neuroimaging. That's because we just read, no, doctor? See,
Yes, yes.
where did we read? Where was it? NICE recommends seeking specialist advice from neurologist if a patient develops cluster headaches. Okay, that is the first line in
Yes,
management.
yes.
So seek a specialist advice from neurologist first. Then you can give restorative treatment. You're doing a medication review for a woman who is prescribed the combined oral contraceptive pill. Which one of the following would not decrease the effectiveness of the COCP? Rifampin, sodium valproate, carbamazepine, St. John wort, phenytoin. Which would not decrease the effectiveness means which will not induce the enzymes. So which one is not an enzyme inducer? Rifampin is not an enzyme inducer. Sodium valproate is also not an enzyme inducer. St. John's wort is
It is.
an inducer. Carbamazepine is an inducer. Phenytoin is,
It's also the best one.
yeah, phenytoin is the inducer, right? So two groups are there, no? But then in the enzyme inducers also different classes of enzymes are there. Maybe that's why.
I think the first one does not decrease the effectiveness of OCPs.
Rifampin, we are going with rifampin.
Yeah, feel like that.
Okay. Sodium valproate, they are saying. Sodium valproate is a P450 enzyme inhibitor. That I also know. But what about rifampicin? Rifampin is a potent inducer of hepatic enzymes, particularly those in cytokine. Yeah, of course, right? I forgot. Rifampin is the only antibiotic that's an inducer, right? Oh, that's why I got confused. Okay, so sodium valproate it is.
This enzyme inducer and inhibitor, they are confusing us too much.
Yeah, they are confusing. Yeah,
And
I
especially,
just read
especially
that.
with these drugs, anti-epileptic drugs, we are getting more confused.
Mm, okay, so this one is there. So, question number 20. A 28-year-old female has presented with symptoms of clumsiness and has noticed that her legs have become unusual shape. She states that the bottom of her legs around her ankles are becoming much thinner. This one, last question yesterday. Feel weaker over the past few months. Quite concerned, and she's usually quite active and fit. She never had to come to the doctors before. Which one of the following is most likely diagnosis for her? Cerebral palsy, no. Guillain-Barré, no. Mononeuritis, no. Duchenne muscular dystrophy. It is seen in only males, it seems. Duchenne muscular dystrophy is an X-linked eye-thin recessive. So, Charcot Marie tooth disease. It was yesterday we saw. Cause for distal muscle wasting. This lady has features of distal muscle wasting and weakness, both features of Charcot Marie tooth disease. Duchenne muscular dystrophy typically affects the males and very rarely affects the females. So, Charcot-Marie tooth disease, most commonly hereditary peripheral neuropathy. In this results in predominant motor weakness, loss. There is no cure and management focused on physical and occupational therapy. There may be history of frequently sprained ankles, foot drop, high arched feet, hammer toes, distal muscle weakness, distal muscle atrophy, hyporeflexia, stalk leg deformity. Hyporeflexia is also seen. Even muscles are wasted and reflexes are also less. So only two questions are left here. Which one of the following anti-epileptic medications carries the greatest risk of neurodevelopmental delay if used in pregnant women? Maximum risk. Carbamazepine, sodium sulfate, topiramate, phenytoin, lamotrigine.
Control causes the control baby syndrome, some gray baby syndrome, but neurodevelopmental delay, I'm not sure.
Topiramate.
Sodium valproate. Sodium valproate. Sodium valproate. Phenytoin cause cleft lip. I think so.
Oh, topiramate.
And phenytoin also causes fetal head and toin syndrome. It causes the phenytoin, fetal head and toin, but it's saying the neurodevelopment delay. Sodium valproate, that is anti-epileptic, no?
Yeah. Phenytoin is also anti-epileptic. Topiramate is also anti-epileptic. Of course, all these options are anti-epileptic drugs, doctor. This is the greatest risk they are asking of neurodevelopmental delay if used by
You know,
pregnant women.
they have stopped in the childbearing age. Sodium valproate now contraindicated due to this reason, neurodevelopmental delay.
Okay, let's lock it. Sodium valproate carries a significant risk of neurodevelopment delay if used in pregnant women. Very rightly correct question. So, correct answer is sodium valproate. This is because sodium valproate has been associated with significant risk of neurodevelopment delay in offspring when used by pregnant women. According to UK NICE guidelines, it should not be used in pregnancy unless there is a suitable alternative. It carries a risk up to 40% for neurodevelopmental disorders, which include autism, low IQ, and learning disabilities. Okay. Carbamazepine is less risky compared to sodium valproate, but still carries a little risk of causing congenital malformations, not neurodevelopmental delays. This is malformations like spina bifida. However, risk of neurodevelopmental delay is significantly lower than that of sodium valproate. Topiramate, similar to carbamazepine, carries a risk of smaller risk compared to valproate. There's an increased risk of cleft lip or palate from overall, but the overall risk of neurodevelopment delay is less than that posed by sodium valproate. Okay, topiramate also cleft lip and cleft palate and less neurodevelopmental delay. Phenytoin poses a risk to the fetus if used during pregnancy. Doctor, you need to mute yourself, please. Poses a risk to the fetus if used during pregnancy. It is known for causing fetal hydantoin syndrome, which can result in growth retardation. So, fentanyl poses a risk if the fetus is used during if used sorry risk to the fetus if used during pregnancy. It is known to cause fetal hydantoin syndrome. Correct, doctor? You have just correctly said that, which can result in growth retardation, developmental delay, and craniofacial abnormalities amongst others. However, its potential for causing neurodevelopmental delay isn't as high as that. Okay, neurodevelopmental delay means only three things are considered here: autism, low IQ, and learning disabilities in the kid. Okay. Other congenital malformations, teratogenicity with as far as physical development is concerned, that is not considered as neurodevelopmental delay. That is the reason why the other options are not right. Lamotrigine considered safer to the anti-epileptic during pregnancy. NICE guidelines suggest lamotrigine alongside levetiracetam as one of the preferred first-line treatments for focal seizures and generalized tonic-clonic seizures in women who are pregnant or who plan to become pregnant due to slow risk of teratogenicity and adverse neurodevelopmental outcome. So there is low risk of adverse neurodevelopmental outcome with lamotrigine. Epilepsy, pregnancy, and breastfeeding. So, the risk of uncontrolled epilepsy during pregnancy generally outweighs the risk of medication to the fetus. All women thinking about becoming pregnant should be advised to take folic acid 5 milligrams per day well before pregnancy to minimize the risk of neural tube defects. Around 1 to 2% of newborns born to non-epileptic mothers have congenital defects. This rises to 3 to 4% if mother takes epileptic medication. So, double. Other points. Aim for monotherapy. There is no indication for monitoring anti-epileptic drug levels. Sodium valproate associated with NTDs. Carbamazepine, often considered least tetracentric of the older antiepileptics. Phenytoin, associated with left palate. Lamotrigine. Studies today suggest rate of congenital malformations may be low. Breastfeeding is generally considered safe for mothers taking antiepileptics with The possible exception of barbiturates. So if you're taking barbiturates, breastfeeding is not safe. It's advised that pregnant women taking phenytoin are given vitamin K in the last month of pregnancy to prevent clotting disorders in the newborn. If they're taking phenytoin, they should be given vitamin K in the last month of pregnancy. Sodium valproate. Up to date concludes that sodium valproate should not be used during pregnancy and women of childbearing age unless clearly necessary. Women of childbearing age should not start treatment without specialist neurological or psychiatric advice. Significant risk of neurodevelopment delay in children following maternal use of sodium valproate. Drug safety update. A 68 question 2 out of 2. 68-year-old female presents to GP with a 2-week history of intermittent headaches and lethargy. Blood test revealed ESR is 67. So intermittent headaches, lethargy is also there, huh? Headaches is fine, temporal arteritis, lethargy, polymyalgia rheumatica. What is the most likely diagnosis? Polymyalgia rheumatica, cluster headaches, polyarteritis nodosa, migraine, temporal arteritis.
Oral arthritis.
What about lethargy, doctor?
What?
Lethargy.
Headache, both.
Headache is fine,
First,
doctor. Headache is fine. Temporal arteritis is a headache. Okay, intermittent
okay,
headache.
then,
ESR is fine.
yes.
Jaw
And the
claudication.
headache is intermittent. So
Then polymyalgia rheumatica. Yeah. Polymyalgia.
No, only thing here that suggests away from temporal arteritis is lethargy. Lethargy suggests it's a systemic disease, no? I'm also not sure. I'll mark
in
temporal.
PMR, ESR is greater than 40.
Mm. Yeah, in temporal arteritis.
So increased.
But it's only lethargy, not proximal muscle weakness. Huh?
I think
Temporal arteritis, because it is saying she has lethargy, but it's not saying proximal muscle weakness. So polymyalgia rheumatica will have proximal muscle weakness. There is a classic history of temporal arteritis. Treatment should be started immediately with high dose of steroids, prednisolone 1 milligram per kg per day to reduce the chance of visual loss. You are absolutely right, doctor. I only confused you. So temporal
it's
arteritis.
okay. No problem.
And in polymyalgia rheumatica, I think younger age. We will clear this
No,
point.
no. Both are older age, but as she said, proximal muscle weakness.
Yeah,
Okay.
here there is only lethargy, but in the PMRC, 50, around 50% have features of PMR, that is aching, morning stiffness in the proximal muscles, not
Not
weakness,
a
not even
weakness.
weakness, huh? I'm wrong there also. Morning stiffness will be there in the proximal limb muscles, which will improve on working it out. But aching and morning stiffness in limb muscles is seen in PMR. That was not there in our question. Lethargy, depression, low grade fever, anorexia, night sweats are systemic symptoms of temporal arteritis. So I'll read everything of this. Also known as GCA, giant cell arteriitis. It's a vasculitis of unknown cause that affects the medium and large size vessels arteries. It occurs in over those over 50 years with a peak incidence who are around 70. It requires early recognition treatment to minimize the risk of complications like permanent loss of vision. Hence, when temporal arteritis is suspected, treatment must be started promptly with high dose prednisolone as well as urgent referral for assessment by specialist. So, what the GP should do is promptly start a high dose prednisolone and then refer to a specialist. There's an overlap between the temporal arteritis and polymyalgia rheumatica. Around 50% will have features of PMR. Features typically present more than 60 years, usually rapid onset less than 1 month, headache found in 85%, jaw claudication 65%. Vision testing is key investigation in all patients. Anti-ischemic optic neuropathy accounts for majority of the ocular complications. It results from occlusion of the posterior ciliary artery, a branch of the ophthalmic artery. Ischemia of the optic nerve head. Fundoscopy typically shows a swollen, pale disc and blurred margins. May result in temporary visual loss, emesis fugax. Permanent visual loss is most feared complication. Temporal arteritis may suddenly develop. Diplopia may also result from involvement of any part of the oculomotor system, example the cranial nerves. Tender palpable temporal artery, 50% have PMR symptoms like aching, morning stiffness in the proximal limb muscles. Also, lethargy, depression, low-grade fever, anorexia, night sweats. In investigations, raised inflammatory markers. ESR is raised more than 50. ESR less than 30 in 10% of the patients. CRP may also be elevated. So ESR, even if raised or not raised, if there are these symptoms, we should think in these lines because in some people it is not raised. 10% of the patients. Temporal artery biopsy, skip lesions may be present. Note creatinine kinase and EMG are normal. Since even if they are having proximal muscle stiffness, CK and EMG will be normal. Treatment. Urgent high-dose glucocorticoids should be given as soon as the diagnosis is suspected before temporal artery biopsy. If there is no visual loss, high-dose prednisolone is used. If there is evolving visual loss, IV methyl prednisolone is usually given prior to starting high-dose prednisolone. So, oral prednisolone you will give when there is no visual loss. When there is evolving visual loss, you should give IV prednisolone. There should be a dramatic response if no diagnosis should be considered. Once you give steroids, there should be a dramatic response. Urgent ophthalmology review. Patient with visual symptoms should be seen the same day by an ophthalmologist. Visual damage is often irreversible. Other treatments, bone protection with bisphosphonates. So you're starting steroids for a long time. Bone protection with bisphosphonates is required as long as tapering course of steroids is required. Low dose aspirin is sometimes given to patients as well, although the evidence-based supporting this is weak. 60 milligrams prednisolone as one-off dose is advised, and then they should be referred to ophthalmology review the same day. So first give 60 milligrams prednisolone and then review, send them to ophthalmology review.
So we finished neuro.
Not so soon. We finished some topics of neuro. Only these many topics we have finished. We are at C. So we'll continue tomorrow. Tomorrow is
Okay, doctor.
tomorrow is Friday.
Tomorrow. Yes, at what time we will have class tomorrow?
Tomorrow holiday for you.
Yes, but tomorrow I need to go to my child's school because he has exhibition. They have a result declaration and everything.
Nice, nice. So tomorrow no class for you for
No,
school.
in evening if it is there, I will attend. Afternoon I will go.
No, tomorrow evening I have some other
Oh,
work, so maybe not possible. Day after tomorrow also maybe not possible, but I will let you know by evening if at all it's possible to take the class. So 2 days
okay.
holidays in a row for you. After that we will continue.
Morning,
So
even
for
morning,
tomorrow,
ma'am.
for others also no class.
Yeah, for others also no class.
So you are taking off actually yourself, doctor.
Yeah, I'm taking off.
This is unfair, doctor. When we will ask for the off, you will not give us off. But yourself, you are taking off.
Okay, okay. Good night.
Okay, good night.
Thank you very much, Doctor.
Thank you.
Good night.
Thank you so much.